A child with developmental delay and focal epilepsy is referred for neuroimaging. I'm showing you an axial T2 weighted MRI of the brain. Describe the findings.
Okay. The axial T2 weighted brain MRI demonstrates a large, CSF-filled cleft extending through the full thickness of the left cerebral hemisphere, from the ependymal lining of the left lateral ventricle to the overlying peel brain surface. This cleft is lined by gray matter, which appears thickened and dysplastic. These findings of a full-thickness cleft lined by gray matter represent the open lip type of schizencephaly.
I'm showing you 3 additional brain MRI sequences demonstrating related anomalies. Describe the findings in each and explain the spectrum of neuronal migration abnormalities.
In that case, the first T2 MRI shows a nodular area of subependymal heterotopic gray matter adjacent to the left occipital horn, which is iso-intense to cortical gray matter on all sequences. The second Coronal T1 MRI shows a bumpy, irregular appearance of the right temporal lobe gyri, indicating polymicrogyria, whereas the left temporal lobe gyri are normal and distinct. The third Coronal T1 MRI depicts a smooth brain surface with almost complete absence of normally formed gyri, typical of lissencephaly. This spectrum represents arrested migration of neuroblasts from the periventricular germinal matrix to the cerebral cortex during gestational weeks 8 to 16.
How can we differentiate schizencephaly from porencephaly, and how does closed-lip schizencephaly differ from open-lip schizencephaly?
Well, schizencephaly and porencephaly both present as fluid-filled cerebral cavities. However, schizencephaly is a congenital migration anomaly where the cleft is lined by dysplastic gray matter, whereas porencephaly is an acquired encephalomalacic cavity from in utero vascular insult, lined by white matter and gliosis without gray matter. In open-lip schizencephaly, the cleft walls are separated and filled with CSF. In closed-lip schizencephaly, the walls are closely opposed and can be very subtle, but they are identified by a focal, nipple-like irregularity or dimpling in the ventricular wall at the site of the cleft.
How do we distinguish subependymal gray matter heterotopia from subependymal nodules in tuberous sclerosis on MRI?
Okay. Subependymal gray matter heterotopia is composed of normal neurons that arrested during migration, so it remains strictly iso-intense to cortical gray matter on all MRI sequences, including T1, T2, and FLAIR, and does not show enhancement or calcification. In contrast, subependymal nodules in tuberous sclerosis represent hamartomas and follow white matter signal intensity, often showing calcification on CT or susceptibility-weighted MRI. And they frequently exhibit contrast enhancement. They are also typically located along the caudothalamic groove.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing these MR images with prior fetal ultrasounds or postnatal head scans. I would suggest clinical correlation with pediatric neurology for seizure control, as anti-epileptic drug management is the primary treatment. I would document the extent of the cleft and screen for associated midline abnormalities, such as septo-optic dysplasia or callosal agenesis, which often coexist with migration anomalies. Finally, I would refer the patient for comprehensive developmental and genetic evaluations to support the family.